just a few more moments. Give everybody a few moments to join us, and then we will get started. We are super excited about our guest today and the information that we're all going to get the benefit of learning from today. So I hope you guys are all enjoying your summers and that you're having the opportunity to get some rest as much as one can when you're a caregiver of a child with special health needs. But at least a little bit of a break, hopefully, from the drudgeries of the IEP process and having a little bit of fun and everybody really frolicking in the water or up in the mountains, wherever you prefer. So, but I want to welcome you. My name is Elizabeth Bostick, and I am here to facilitate this month's Connecting Families. If you are someone who requires translation and interpretation, there is a link in the chat that will be provided very soon so that you can actually have what is being discussed in your language of choice. So that will be coming very soon. But we are super excited tonight to have our guest here. Tonight's topic is on fetal alcohol spectrum disorders. I've had the pleasure of meeting both of our presenters in the past because they have also presented for our division for children and youth with special health needs at DPH, and you are in for a bunch of wonderful information that will be very useful. And I think you'll be a little surprised at the information that we'll hear and may possibly provide some insights on some things that you may have been seeing and didn't know what to call it. But with us tonight, we have Kristen Eriksen, who is the FASD caregiver navigator and trainer. She has worked as a registered nurse with over 35 years of experience, including pediatrics, obstetrics, early intervention, and school nursing. She basically started when she was 5. And her personal history is of raising twins with fetal alcohol syndrome since infancy has led her to training, advocacy, and support work. So thank you, Kristen, for joining us this evening. And her partner in crime, Reuben Kittrell, is the FASD Services Coordinator. He has a background in addiction treatment and mental health, and he specializes in a variety of approaches, particularly in trauma-informed care, motivational interviewing, and crisis management. His work focuses on training as well as creating, supporting, and maintaining educational and advocacy initiatives for FASD to offer crucial support to caregivers and professionals. So welcome, Reuben. We will, both Reuben and Kristen will actually do their presentation. I will, of course, be monitoring the chat. So if there are questions along the way that fit well into the presentation, because I have seen much of the information, then I will insert them. But, and if not, then please know that at the end of the presentation, we will open it up for questions. So please, if you can put your questions in the Q&A, that would be extremely helpful. And also, while we are recording, if you're not speaking, if you could please mute your microphones, that would be extremely helpful. We really appreciate that. And again, if you're in need of interpretation services, please use the Wordly link that's in the chat. All right, so without further ado, Reuben and Kristen, please tell us about fetal alcohol syndrome and the disorders.
All right, thank you. Thank you so much. We're happy to be here. I'm going to go ahead and start by sharing my screen. And can everybody see that clearly?
Looks good to me.
All right, awesome. So my name, again, thank you for the introduction. My name is Reuben Kittrell. I serve as the FASD Services Coordinator at MassFAS, which is a program of the Institute for Health and Recovery.
And my name is Kristen Eriksen, and I am the FASD Caregiver Navigator and a trainer at the Institute for Health and Recovery in MassFAS as well. I also share that first and foremost, I'm a parent of twins who have an FASD. They have full FAS and they are 17. So I will take any prayers that you want to send my way. And as Elizabeth said, I have been working for a lot longer than how old I am. I just think there's a clerical error in my date of birth, and that's what I say. And Reuben could say the same thing, only you'd know that he's only 6 now. So, okay, you can go ahead.
But almost.
Yeah. As a side note, also, I also work part-time for FASD United, which is the national voice, and we'll talk a little bit about that at the end, the national voice for FASD education and support. And I work there also as a caregiver, family navigator, sharing resources. Okay, you can go, Reuben.
And she does more than she's explaining too. So a little bit about our agency, the Institute for Health and Recovery. So for those of you who, whether you are familiar or not, here's a bit of a refresher. We are a nonprofit organization in Massachusetts. We have a wide range of services. We essentially have two different arms. We have one that is more counseling and referral services, and where the other arm is training, technical assistance, and consultation, which is what we fall under. So our program again is called MassFAS. We are funded through the Bureau of Substance Addiction Services at the Department of Public Health. What we do is we offer trainings like this, technical assistance, direct support, and consultation to a wide range of organizations that includes schools, that includes treatment programs and institutions of all different kinds. And basically, we're very fortunate we're able to work with just about any program in Massachusetts and help and support around New England in general. We also do what Kristen was talking about, which is caregiver navigation. So what that looks like is we support families, caregivers, and parents around the state of Massachusetts who are impacted by fetal alcohol spectrum disorders. Whether there's a diagnosis in the picture or there's a suspected FASD, right? So we help them with resource navigation, exploring diagnostic options. Kristen facilitates and organizes twice a week caregiver support groups, which are spectacular. We have an awesome network, and we also hold events for our families, like an annual apple picking, Museum of Science, and some other fun stuff like that.
I like to say we're small but mighty. Go ahead.
Small but very mighty. Absolutely. Dynamic duo. So what we like to do at the beginning of any presentation, any training, any conversation is we like to gauge the people that we're talking to, because that's important, right? So the first thing I want to ask all of you, if you could kindly throw it in the chat, would be how well do you understand fetal alcohol spectrum disorders? Whether that's less well, fairly well, or very well. And if you're more comfortable sending it as a private message, that's fine. We just like to see where everyone's at. Give everybody a minute or two to do that.
I'm getting some less well and fairly well. Oh, I have someone else who's already excited to have learned about us and fairly well, less well. I would say a little more less well than fairly well.
Oh, wow, Megan. Throwing out good information already. Yep, so less well, fairly well for the most part. That is pretty standard.
I'm wondering, I'm sorry. I didn't mean to tell you about.
No, all good. We usually get less well to fairly well. Very well is very rare, which you'll find out more about why very shortly. This is a very under-discussed and under-recognized disability, and also just the topic of alcohol during pregnancy, substances during pregnancy. We know why it's stigmatized. We understand there's a level, many reasons, but we'll talk a bit about that as well shortly. But before we do, let's go into background, right? So what is fetal alcohol spectrum disorder? What is FASD? This is referring to a lifelong and brain-based disability that occurs due to prenatal alcohol exposure. This causes a wide range of impairments, whether that's physical, behavioral, or cognitive. Now, a couple of noteworthy things that we always like to mention when we talk about a brain-based and lifelong disability. Talk about lifelong. Number one, we're looking at through the lifespan. So when the intrauterine insult happens, when someone drinks during pregnancy, doesn't definitively mean that an FASD will occur. But if it does, it starts then, and it continues through the lifespan of that individual. Now, when we talk about brain-based, it's important to recognize that the characteristics, the symptoms, and the behaviors that these individuals may exhibit are unintentional, right? And we know that with neurodevelopmental disabilities often, but with the level of stigma to this subject, it's often under-recognized because there is differences and it's such a unique profile for these people. Also, just to note, this is not a clinical diagnosis. This is used as an umbrella term. So under that umbrella, with our great little cartoon umbrella right there, we have fetal alcohol syndrome, which is a diagnosis that you're all probably most familiar with. This is the oldest diagnosis, and because there are facial features involved, which I'll explain shortly, it is the most recognized. Usually when I say FASD to someone, or fetal alcohol spectrum disorder, they say fetal alcohol syndrome back to me. It is very common. It does not bother anybody. It is absolutely a diagnosis. So fetal alcohol syndrome is referring to the cognitive profile that everybody with an FASD diagnosis will have, along with prenatal alcohol exposure. With fetal alcohol syndrome, they have three primary facial features, and I'll show you a picture after this slide. They have short palpebral fissures, those smaller and rounded eyes. They have a smooth philtrum, the area between the nose and the upper lip, and then a thin upper lip. They also have a vermilion face, so a flatter kind of face. Microcephaly, a smaller head circumference, abnormal brain structure, growth deficits, and a number of things that are involved with this diagnosis. Now, similar to that is partial fetal alcohol syndrome. So it doesn't meet all the criteria, meaning that it only has some facial features and some physical differences. But it also has the cognitive profile and then the alcohol exposure prenatally. Now, what people often don't know is that people with an FASD who have facial features, so these two diagnoses, only make up about 10% of the population of people with FASDs. Now, the majority, about 90%, do not have any facial features or identifiable physical differences, and they fall under these two categories: alcohol-related neurodevelopmental disorder, ARND, and neurodevelopmental disorder associated with prenatal alcohol exposure, NDPAE. Now, again, these two have that cognitive profile, which is very unique to the individual, depending on timing of exposure to alcohol, which I'll talk about a little more shortly. And then they also have the history of alcohol exposure. The reason I have that little DSM-5 note there, and this may or may not be applicable to you, but it's always helpful to know. I think that everybody, a team is made up of a family, providers, and everyone. So it's always really important and helpful to know about the little things that we may miss, right? So when we're looking at diagnostic manual, when there is a history of prenatal alcohol exposure that could potentially be there or be identified, that fourth diagnosis there is one to consider or to bring up with providers or with families or with whoever, based on your role in the picture. Now, just to give you a quick image, when we talked about those facial features that are only present in, again, 10%, you're not going to be tested on this, but you might be. And so these facial features that I was talking about with the fissures around the eyes, as well as the philtrum and the thin upper lip, you can see here. And we're gonna send these slides and information over to the team, and they'll be able to send it out to everyone as well. We're always happy to share information and be a resource. So a little bit about how alcohol impacts a developing fetus. This may be not new to you at all. This may be brand new information, and we're happy to always continue this conversation. So alcohol is a teratogen, meaning that it interferes with quote unquote normal fetal development. So what would be kind of standard fetal development, and can cause a range of congenital disabilities. This can be chemicals and toxins, and then can also be substances of misuse, and alcohol as well, including alcohol like cocaine, cannabis, alcohol, ketamine, whatever, that are substances that are misused. This also causes an increased risk of a bunch of different potential issues like miscarriage, preterm labor, or stillbirth. It does, and I just want to emphasize, it's not definitive. These are potentials, right? One of the big things that I always like people to take away from this part, and one of the biggest messaging that people don't really know, is that out of all substances that are frequently misused, like the ones I mentioned before, alcohol has the greatest neurobehavioral effect on the fetus. So that includes cannabis, opiates, so on. So some factors that impact the developing fetus. Timing of exposure, that's a big one, right? So when alcohol is introduced in utero, it's going to impact whatever developing system is forming at that time. Earlier on is when the facial features that we talked about are formed, and we'll talk about this a little bit again, but typically in the beginning, up to 6 weeks plus, almost nobody knows they're pregnant. So early on, when there's alcohol consumed, when it's exposed, are when the facial features are developed. And then through the span of pregnancy, it can affect different developing systems. The resiliency of the fetus. So when someone's in a situation where they're in higher stress, right, whether that's a lower socioeconomic situation, they're facing, abuse or whatever might be happening in their home or in their community or in their day-to-day life, smoking, those kind of things are going to in turn affect them and affect the resiliency and bounce back of the fetus. Diet is a big one, right? So for anybody, we know that typically a more healthy diet is good, and a less healthy diet can negatively impact us. For a pregnant person, the impact on the fetus looks like a bunch of different things, and when there's not including necessary vitamins like iron, protein, folic acid, and choline. We're often, people often don't know that they're pregnant for a period of time, or are not going to regularly schedule doctor's appointments. So it's always important to go to the doctor, but also to encourage others to, because if you're not going to see your OB, you're not going to know what to include in your diet. And then lastly, just looking at metabolism and blood alcohol content. So the blood alcohol content, we're thinking about, of course, how much they drink. And then with metabolism, we're thinking about how the fetus is a immature metabolism. So any damage that may happen to the liver of the parent is going to slow down that metabolism and potentially harm it. So here this is a really big piece that I like to address because it's crucial, even though it can be difficult. We're talking about use of substances during pregnancy, and there's kind of two things that I'm getting at here. One is reasons as to why someone may use or misuse substances throughout pregnancy, and then number two, as to why fetal alcohol spectrum disorders, FASDs, are never going to be 100% preventable. We know that, we understand it. Prevention is not the hyperfixation. It happens through education and awareness, but supporting people to understand this disability and support people around them is what's important. It's what's really important. So reasons as to why people may use or misuse substances, for example, lack of prenatal care resources and misinformation. We see it all the time. We speak to a whole wide range of people with lived experience, professionals all across the country, sometimes internationally, and most people don't know about this stuff. So that's to normalize it for a lot of you too. It's okay if this is brand new. It's okay if you had misconceptions. It is absolutely normal. I think my cat's joining us.
And I will add that in my own experience as an OB nurse and in other jobs I've had as well, that there is misinformation. There are people who will say it's okay to drink a little if it's not too often, or it's only early in pregnancy, or there are doctors who don't discuss it. So it's completely, the misinformation comes from every angle.
Absolutely. So with that being said, substance use disorders, are also a reason as to why someone may use or misuse during pregnancy. With that being said, we also understand harm reduction very well. I come from mental health and SUD treatment background. I'm a big advocate for it, safety first for everyone. Substance use disorders, though, increase the likelihood. Just one of the things that we talk about, oh, that's what happens when you have a cat. One of the things that we talk about here is how there are a lot of reasons as to why it's never going to be 100% preventable, and as to why people may use or misuse throughout pregnancy. With that being said, one of the difficult conversations that happens at times, which we're not telling anybody anything, we're also not, but it's important to recognize that that any amount of alcohol could potentially cause an FASD. Now, again, there's many reasons as to why someone may still use or misuse alcohol and other substances, but it's important to just recognize that, so we know, because when we talk about misinformation, it's normalized to be misinformed with this, just because there's not a lot on it, and it is so stigmatized. So we do have a lot of these conversations with caregivers, with professionals, doctors, government officials. This is every day. We do a lot of advocacy too. So that is a big part of the message, but we always meet people where they're at. With that being said, mental and physical health conditions can play a part as well, depending on where someone's struggling, where they're at, if they had a dependency on something, different kind of medication. Influence of friends, family, and culture. There are many cultures where using or alcohol, tobacco, other substances throughout any phase of life, including pregnancy, is normalized. Traumatic and abusive relationships, whether that be friendships, familial, romantic, or institutional, right? So different power dynamics, those will definitely play a part. And then last but very, very important, unplanned pregnancies, right? So when we talk about, they say about half, I think it's 49% is the current statistic, but stats are always conservative, of people do not know that they're that don't intentionally get pregnant, or unplanned pregnancies. This happens for a whole wide range of reasons. This can include someone being told that they're infertile. This could include someone not knowing about protection or safe measures, just not part of the plan. And then again, like I said earlier, for the first 6 weeks plus of pregnancy, someone's not going to know that they're pregnant. So we often have those conversations with people who may reach out and say, I found out I was pregnant when I got back from vacation, or I found out I was pregnant after I got out of a program, or whatever it might be. So now we're going to go ahead and talk about how common it is.
So thank you, Reuben. So there's a study that was done by a Dr. Phil May out of UNC Chapel Hill in 2018 that was the most extensive study to look for prevalence for FASD. And what they did was go into first grade classrooms in different areas of the United States, some rural, some urban, trying to get a good cross section. And they had a test group of 6,500 children, and they did a screening tool for whether these children would meet the criteria for an FASD diagnosis. And what they found was that their original estimate actually was 1 in 20, but then with more looking into and doing a deeper dive study, they actually came out with it's more like 1 in 15. And that is what Megan said about it being 2.5 times more prevalent than autism. When they did this study, they ended up finding they had 220 children that met the criteria. And of those, only 2 actually had a diagnosis. So the other ones were undiagnosed, but they met all the criteria. And it's estimated that this is a conservative number because they were they had to get parental consent, and they got that from about half of the parents. And so you can, it's hard to say whether it would have been the same in the same numbers range or if it would have been higher. And why did those parents not give consent, which could be for many reasons. And so it's hard to say that for sure. But this was the most detailed study, and Dr. May is doing continued work and studies on this. But 1 in 15 is one kid in every classroom, or 1 in 20 is 1 in 15 is less than that. It's how many out of this room, and it is so unrecognized for all the reasons that we said. The fact that the rule had initially always been you need the facial features, and now they've found that 90% don't have facial features. And the other thing, and this is what I would say, in my own personal life with my children, is that they are polar opposite kids. They are twins, but they do not present with the same, like you wouldn't even think it's the same diagnosis, except that it is. So it's some of the interesting things. Now, when we want to get into like a little more detail here about what the characteristics are, and like Reuben said already, one thing to remember is that if you know about the developmental, those charts they have about fetal development, and you can look at what part during the pregnancy is each part of the body formed. That's how you can look into how many systems can be affected by the exposure to alcohol at that time. And so that's, early on, along with the face is ears and things like that. With ears also goes kidneys at that same time of development. There can be muscular disorders. There's GI disorders, all kinds of things. So it's a disability that can be so different for everyone involved. And like I said, even with my kids in their same intrauterine environment. So one area in the brain that can be affected is in the processing, and their processing is slow. It can be auditory, it can be reading processing, it's in visual processing, every area of processing. And one thing I like to put in there is the idea that the neurons in the brain normally have smooth connections where they need to go in the brain. It's almost like in this case, because of the effect of alcohol during that time, those connections are bumpy roads or gravel roads with ice on them, or sometimes the connections are not going to the right place. I do talk with my hands, but that because of that, they cannot get the information where they need it to process it. They also have memory problems. I think that's our next one there. And that's the same idea. They may learn something and have it in their mind that, and they've learned it, they're in school, they've had a test on it. And then 2 weeks later, the teacher could say, okay, we're going to do review here. And they cannot access that memory from their brain to bring it down through the highways, to bring it where it needs to go. And if anybody knows about brain science, to any degree, the corpus callosum is the middle part of the brain, and that is the piece that connects the two sides, and it's kind of like the bridge that helps with bringing memories from long-term to short-term, all those things. In individuals with FASD, the corpus callosum they usually have agenesis of the corpus callosum, or many times they do. And so that piece is tough. They also pretty typically have sensory differences. And I know, we've talked a little bit about the autism piece. There's a lot of crossover with autism symptoms and FASD as well. And this is where I say, my kids, I have a sensory seeker and a sensory avoider, and they're twins. Impulsivity is a huge thing. Now that would lead you towards thinking ADHD, but this is impulsivity on steroids. Impulsivity will trump everything. They just cannot stop when they see the squirrel. You can go on to the next one, Reuben. Thank you. Now, again, these are all the primary characteristics that go with the disorder and start young, etc. I need the words for this one. Yeah, okay. They're extremely concrete thinkers. Any idiom that you use, they're going to not understand and be able to understand those, hold your horses. I can't think of any now off the top of my head, but
Beat around the bush.
Yeah, what'd you say?
Beat around the bush.
That's right, exactly. You can't use those, or you can, but they will not understand them. I remember one time I said, "Hold your horses," and my daughter was like, "We don't have horses, Mom." And but it also means that they cannot generalize what they learn to use in a different situation. So in a situation where they get in trouble, they're not going to then say, wait a minute, when this happened before, this was similar to something else. I shouldn't do that. They don't have that ability. Rigid thinking, it's black, it's white, and that's it. There's no gray. The other thing, and this is in language communication, and just where also Reuben mentioned the cognitive profile, a lot of times what you will see is an enormously scattered profile in their skills. When you have a neuropsych eval done, and their language, their expressive language is actually usually very strong for them. And yet their receptive language and their understanding of language and reading is way behind that, which makes it hard for them because they can talk eloquently and people don't believe that there's a difficulty, but then they have a testing done and they don't understand the concepts. We got our little red warriors. Red shoes is sort of the thing for FASD. We use red shoes a lot. It's red shoes rocks, like stand out, be different. And another very common thing with FASD is dysmaturity. There are many times when they are acting and they feel that they really are half of their age. It's not that they're being immature. This is where they are at. And if they are at that level, then number one, you got to think about the fact that you've got to handle them differently. And their behaviors, which I like to call symptoms, are actually going to be much younger than they are. And then secondly, that I don't know who's, Megan knows a lot. She's going to have to join our team. But also that I've lost my track on that, but that they're going to take twice as long to mature. And that's also kind of like their trajectory on learning tends to be twice as long. They're not ready to fly the coop at age 18, maybe 36, 40. So if you have these primary characteristics, then if you are not accommodated well, if you are misunderstood, you will then start to possibly have secondary characteristics if you have FASD. And these are things that are sort of from that being misunderstood. And this is the frustrations, the tantrums, when they are dysmature and they're acting younger than they are. And, what basically starts to happen is that they're looked at as they're doing this on purpose. They're just trying to avoid a situation they don't want. They also have anxiety troubles. They have that low self-esteem, especially if they're starting to realize, or people are not realizing, that they have these memory issues. And they keep saying, this, we did this last week. Then they start to feel much worse about themselves. They can be isolated. They can start to have issues where they are not having school refusal and truancy, acting out sexually, and just a slew of symptoms that make things more difficult. And sometimes this then leads in the typical school system to behavioral plans and token reward systems, which are not recommended for FASD because they do not understand that concept of a token that has nothing, because they're so concrete. Why would a sticker do anything for me doing my homework? And just understanding those concepts. So then if you continue along this road without much support, then you can get into the tertiary characteristics, which are not just skipping school, but quitting school or having more difficulties, disrupted foster placements, substance use disorder, self-harm, more mental health issues with depression, anxiety, being a victim. They're very gullible to other people, and they have a lot of difficulties with social skills. So they want to be part of the group, and that can be hard for them. And then they can be institutionalized or homeless. They often elope. They're not happy wherever they are. They end up in residential care and try to elope from there as well. We can go on to the next one. So I've talked and stuck in a little bit here and there about the other diagnoses, and there are a couple of things to be aware of. There are 428 co-occurring conditions that can occur with FASD. And that means medical, mental health, everything. And that's like I talked about with the development. It could be hearing loss, there could be vision loss, there could be muscle issues, cardiac issues. So it's very important to be aware of, to keep a closer eye on medical things, and also mental health things, which some are a consequence of the misunderstanding of their diagnosis, and some are just also part of the plan or from their family history. I have our little alphabet soup bowl there, because oftentimes what you will see is children are getting the whole slew of diagnoses that are all the letters: ADHD, anxiety, autism, mood, ODD, whatever it is. It's the alphabet soup. But if they went down the whole list and really think about it and research, it is likely FASD, but nobody gets to through the whole list. They stop when they get a diagnosis. So that's the classic one I hear more than anything. Oh, I thought
I'm gonna take us through this little perspective.
yeah, I thought we weren't
So
going to do this.
people with in FASD, because they have such scattered skills and because the profile is so unique, just for an example, right? An 18-year-old who's living with an FASD, they often, like Kristen said, have good expressive language. So their expressive language may be the functional age of a 20-year-old, right? Or living skills of an 11-year-old, reading ability of a 9-year-old, money and time concept of an 8-year-old, comprehension and emotional maturity of a 6-year-old, and social skills of a 7-year-old. So this is just another perspective on what those scattered skills look like, recognizing someone's developmental age across the board, and then their functional ages in all these different areas and more, is far more important than looking at chronological age. So that's just a little thing we like to show. And back to you, Kristen.
I need to be unmuted for that. Oh, sorry. I think that last slide really does talk about the challenge with our kids, because it's sort of like they're all over the place, and it's one of the things that's most baffling to everyone working with them. Why is it not diagnosed well enough? Stigma, for sure. Screenings are not done in appropriate ways, not done enough. Screenings that, Benny, I cannot do it right now. I'm doing this, honey. I'm sorry. They screen sometimes more for other substances rather than alcohol. Sometimes the questions are put out there kind of in not the best way. You didn't drink while you were pregnant, right? And things like that. The whole idea that, do you know that in the long past, they used to use IV alcohol to stop preterm labor? So think about that. There are cultures that have cultural differences. People have their different belief systems around wine. Jesus turned water into wine. It's good. Doctors are not all informed on the most up-to-date information. I saw that, Megan, I love what you put in there about the diagnostic issues. It's very complicated to try and get a diagnosis. And some doctors, I mean, I'm a nurse. When I went through training, we did not get huge training on FASD. It was probably 1 page, and it was the face. And doctors may have gotten the similar amount of training in that. And the more up-to-date things are showing this other information. But if they only believe, oh no, he's fine, he doesn't have the face, a parent's going to walk out the door and say, okay, I guess he doesn't have it. You can go in. Yeah, I know this. We just did a meeting to help families in Rhode Island. And in Rhode Island, they right now have no documented cases of alcohol exposure in any births in that state. Does anybody think that's true? Because I don't. But it's all in how it is tracked, how it is screened for, how the questions are asked. We could go on forever with strategies and things to look at for how to handle this best, but having a good neuropsych that looks at what areas need focus with your child, or in this case who you're working with, whatever the case is for you, but you have to use a brain-based lens. And not a behavioral. I always feel bad if there are BCBAs in the room or people that work in ABA, because it's just not effective for our families. It doesn't mean it couldn't be effective for other people, but it is not effective with FASD. If anyone are professionals, there are different types of trainings that can help you learn more about using a neurobehavioral approach, which quite frankly, I think is a better approach to use with everyone in the world, because it lets everybody look at their differences, focus on their strengths, to be able to then say, this is how we need to help this person, no matter who they are. And, punitive punitive doesn't work. Yeah, you can go on from there. Punitive wasn't the best word there, but another note is that FASD is enormously in higher numbers in the foster and adoptive care systems. And it kind of makes sense for a lot of reasons. If you do have families that are in substance use recovery, in some stages that their child may be removed because of that. Also, these are tough kids, and they tend to be kids that sometimes might be placed for other reasons like that. And they also tend to be in foster care for longer periods of time. And I think that's it. Well, I don't know why it is. There's lots of data. I don't know what it is. But if you have children in foster and adoptive care, it really should be top of your mind to think of that as an option. And I think we're going back to you now, Reuben. Oh, no. Okay, sorry. Sometimes it is a challenge to think about, why do we get a diagnosis? This is not something that there are a lot of services for in our state, but across the country, we are working and moving towards that. I will go as slow as possible, and if I find a therapist that looks like they'll be helpful, I will teach them. We need to keep doing this and make awareness of it, because it is everywhere and people do not realize it. And we need to approach people about it differently, and we need to look at the use of alcohol differently, because it is so prevalent, and because it is so there's so much misinformation about it, and that's why it's not going away. There's a huge lobby for alcohol as well. So we need to find, we have lots of places for therapy. We just need to get the FASD information in there. We need to be able to have things at the Navigator where I work. I love it when I can talk to people about, this is kind of the way you want to set up and have a plan for the rest of your lifespan with this person, this child. And if we work with them earlier, we can maybe not have some of those secondary and tertiary characteristics, which would be the best thing in the world for all of us. So I think that's, part of my big bandstand, and I do want to make sure we have time for questions. So yeah. I think there's a little closing out here, but.
Yep. So at the end, we just wanted to quickly gauge one more time, after this presentation, before we jump into questions, how well does everyone feel that they understand fetal alcohol spectrum disorders now? No better, a bit better, or much better? I think Megan's going to say no.
Please don't say no better. No, I'm only kidding.
Never.
A bit, good, much. And we can always, and the thing is too, this is just a little tidbit, little seed plant for you. We can always give more information. Last thing I'll briefly mention before we open it up, just like we have resources for caregivers and trainings for everyone and all these different things, we do have an opportunity that we present to professionals, whether that's you or to people that you work with who might be or support you or whoever it might be that's interested. This is comprised of professionals. It's all around service enhancement, increasing diagnostic capacity, and professional education around FASD. So you can always reach out to me if there's any interest in that specifically too.
All right. And I want to, you have one more, I think, right?
Nope, I'm going to stop sharing my screen.
Okay. I already see a question in there, but I also wanted to just say that, if we could give you everything in one shot, we'd have to be here for like maybe a 3-day conference. But with giving you this information, you can reach out to us to get a lot more information. And that's, part of what Reuben and I both do in training is this type of training, and can do other training about, how to work with children with this, how to work with adults with this, what we have for available services. And I do see the questions are awesome, so I'm ready to start with those. The first question is from Margie, is what school services address this? And what I will say is that in the most FASD informed way, not many, or not, probably nothing. Schools are in the same boat. They do not understand. Teachers have so much information that they learn in school, and they have so many trainings that they have to do for their whatever you call it, but they're not aware of FASD. And
But we're able to, whether it's with an IEP team, whether it's with the school staff, if it's suggested or encouraged, whatever it might be, we're able to consult and provide information, education, all that. Like Kristen said, because there's such a lack of information, when we say the number 1 in 15 of prevalence, people typically don't know that. So it is very when they think about the school setting and they have no children who are diagnosed, you can imagine that they're very confused a lot of the times. And also to answer Jean's question about our doctors misdiagnosing this as autism, absolutely, this is chronically under and misdiagnosed. So it'll be misdiagnosed as many things. It can be autism, it can be ADHD, it can be reactive attachment disorder, RAD, and it can look like a lot of things. And these can be co-occurring conditions. We're not saying they're not, but what we see is the pattern comes back to the FASD.
But I just wanted to also get back quickly to, as far as the schools, if they see and understand the specific disability issues that the child has, they can have very effective OT services. They can have very good behavioral services, but they need to know the FASD side of it to not then keep getting kind of sucked into the whole of, oh, we got to take all the privileges away. We got to put this kid in the, because that's where it falls off. Nothing is willful, purposeful behavior. They need extra help and support, and they can't get there without continuing that support. And it's very often misdiagnosed as autism and other things, and has a lot of similarities. Yeah.
This is the second time I've seen this presentation, and I'm always amazed at how much I learn each time I hear the information and just the reminder of how the first time I heard it, I started to wonder, as I started thinking about some children that I know, whether or not this was the missing link, because there has been some struggles that are members of other people, families that I know have been struggling with, and we haven't been able to figure it out. And thankfully, this was information that was actually very helpful for one family in particular. Yes. So we only have about 10 minutes left for tonight. And are there any other questions that anybody has for our guests, Kristen and Reuben, who have done a fabulous job as always?
Thank you.
Could you share a little bit about the effects of FASD across lifespan, cardiac, cancer later in life? What are some other ways this manifests?
Sure. You want me to take that one, Reuben?
Yeah, go ahead.
Again, well, some of the things that they are, they have very better numbers on are that visual issues are way high up there. Cardiac issues at birth are up quite high. There's actually it might be in the things that we're going to send them with the 428 co-occurring. It's kind of interesting if we can send you that that document. It's pretty interesting when you look and you say, oh, wait a minute, like a lot of muscular things, a lot of like lupus and other autoimmune disorders can be in there. And those are the ones that are, and GI. So, so it's something that's very interesting how that it could be. And it's one of those things where, like I said, one of the things I feel most strongly when I talk to families about it is the biggest thing I would say is if there is a medical concern, make sure you have it looked into, because sometimes if a doctor's like, we're just going to be, slough it off, we'll keep an eye on it. Remember to bring that up again, because and we are going to give you a resource list about that. Now, Henry, do you have your hand raised? Do I see?
I do. Thank you. Thank you for the presentation.
You're
Appreciate it
welcome.
very much. Where I'm still need a little bit of help is how it's diagnosed. And just a quick background, going back when I first was exposed to this syndrome, adopting almost 20 years ago from another country, the answer was it can't be diagnosed. So if you could maybe go into that a little bit more, how is it diagnosed and distinguished from some of the other syndromes that you discussed? And thank you very much for the presentation.
You are welcome. There are several different schools of thought on how to get a diagnosis. There's a Dr. Hoyme, Hoyme, had a qualification thing that he used. And that's sort of by characteristics. I know somebody asked about having the neuropsych. There are many places, and we have referral lists that we can send to you for where to get a cognitive eval. And if there's a 4-digit code, which is a different way you can get a diagnosis, which includes looking at, okay, do they have prenatal exposure? 1 through, and there's, these numbers. What's their cognitive profile look like? And is it scattered? And when I say scattered, it's like, I read these different evals all the time, and I've read them, and they'll say things like, well, his processing speed was way shorter in this part, but not in this one. So we can't really score it, but I think he was tired. And I feel like every time I see that, I feel like they're dismissing FASD because they don't understand it, because that is probably that person's true number. But since they can't, they're trying to base it on neurotypicality, they're not seeing that, this is interesting. Why would they have that much processing trouble in memory when they can speak this well, or when this other part of their processing is much higher? But that's exactly why. There are many places. So anyway, that's the diagnostic code. Dr. Ken Lyons-Jones was the one that found the way to measure the facial thing. But again, that's only 10%. And it's a big debate going on in our country about coming to a conclusion.
It'll vary depending on if it's a clinical or medical diagnosis, who's doing it, and it'll also vary in terms of length that it takes, depending on the provider that you go to and how informed they might be. An informed provider, if it's medical, it'll likely be a couple of sessions, maybe a geneticist involved. If it's clinical, a neuropsychologist, it'll likely be a few sessions to really look at all of the 10 brain domains that we can absolutely talk about another another time. But
and executive functioning. Clearly have to look at executive functioning.
Yeah, so yeah, exactly, and that's one of the biggest barriers. So it's looking at all areas of the brain, but it'll definitely vary. And for any true navigation with figuring out potential diagnostic options, yes, we will have that on the list. But please reach out to us, because we're here as an entity to really support and help figure that out. What could be best for the person that you're thinking about, whether that's you or families.
Yep, send them to us. We can offer them our support group. I can talk to them individually and send them what information seems most pertinent for them.
Any other questions before we start to wrap up?
We good? I hope we hear from people, because I love it when we do.
Well, Reuben and Kristen, thank you so much for informing us on a very misunderstood and often unseen disorder, right? A range of symptoms and disorders that are all in one place, but at the same time are so unique that people often don't see it. And how much more are these kids not getting what they need, and how much more misunderstood are they, and how much more frustrated are caregivers who are trying their level best to make sure that these children have what they need. So we really appreciate your giving us a little bit of insight, and absolutely look forward to the resource list that you're going to be sending. We will, of course, be posting the recording and the slides to the Federation's website so that you have an opportunity to collect that information as well. They're not kidding when they say they want to hear from you. They've always been incredibly receptive whenever we've reached out to them. So please take advantage of these amazing resources that are here. And also, as Megan's saying, yes, it's really important to spread the word. So take whatever information you have and share it with somebody else. You may be surprised at how much that could impact somebody's life. And how can I contact the support group?
I'm gonna put her email in the chat right now.
You can put my email in there. You know,
I'm putting this is our program's email. So and we'll have all of our information connected to the other stuff that the team's going to send out to you. And just again, feel free to reach out to any of those 3 emails that you'll receive.
Our website is massfast.org, and on there you can click a link that will put you directly into a place where you can fill out a form that then we will get and contact you, and then can get that information to you or whoever you want that to go to.
We'll make sure that we include that information in our follow-up email to everybody, when they'll be notified that these resources are available to you. So thank you again, Reuben and Kristen, and thank you for everybody else who attended this evening. I just wanted to give you a few things that are going on. You know, one would think this summer would be a quieter period of time, but there's always something going on at the Federation for Children with Special Needs. So I wanted just to name a few of them. One is the CPAC Summer School is underway. So if you are interested in learning more about how to run a CPAC and the resources that are available there, please reach out to us for that. Also, the Parent Consultant Training Institute, there is an in-person version and an asynchronous version that will be, if they're not taking place already, they'll be taking place very, very soon. So please go to the website to learn more about that. I can personally attest, I took mine back in 2005. It was a very long time ago, and it has helped me so much in not only my own advocacy for my children, but in supporting others as well. So much information there that will be very useful to you. Also, if you are a caregiver who is looking for some respite, how many people here need a little bit of a break? The Federation has a new program, the Caregiver to Caregiver Respite Network. It's a fabulous program where caregivers can actually provide and receive support from each other. You know, everybody here who's taking care of a child with special needs has a particular skill set, and that skill set can be used to support others and also for you to be able to receive some support. So if you go to fcsn.org/C2C, you can find out more information about that fabulous program. Also, there are year-round, we always have surrogate parent trainings for people who are interested in supporting our children who may be wards of the state. So please make sure that you take advantage of that. This is an area that is always in need of additional support of these children who may not have their parents who can participate in the IEP process, but need somebody to participate in the IEP process nonetheless. So this is a place where if you're looking for an opportunity to volunteer and make a real difference in a child's life, that's a fantastic one to look into. And also our parent-to-parent network is expanding. Lots of exciting information going on there. So you'll be hearing more about that soon. But if you are interested in being a parent mentor and being able to support other parents who are coming along the way and need some information about some of the nuances of navigating this world called special needs and special education, please reach out to the Federation and let them know that you're interested in that. And on the other side, if you are a parent who is in need of some support, we have often said your best resources when you have a child with special need will be other parents who have been down the road and can give you some insights. Why recreate the wheel twice? So please know that this and many, many other things are taking place at the Federation. I've often referred to it as your one-stop shopping place to find any and all information relative to taking care of and supporting a child with special needs. So take full advantage of it. It is the dream team, people, and you can't do any better. If they can't answer your question right away, they will find someone who can and get right back to you. So that is all that we have for tonight. Thank you so much for joining us. Thank you again, Reuben and Kristen, who has left. We look forward to speaking with you again at our next Connecting Families. And until then, have a wonderful summer, be safe, and we look forward to seeing you soon. Take care, everybody.